Five. All right. So our next presenter is going to be virtual, and is Victoria Burns. Victoria, welcome. Welcome. All right. So she's going to be presenting about, the title of her presentation is Utilizing Data Analytics for Health Centers Reimbursement. Victoria, who I appreciate very much, is the Senior Director of Regulatory Affairs and Reimbursement in our agency, Arizona Alliance for Community Health Centers. I'm really grateful that she's here. She's a very knowledgeable person, and she always, brings the practicality to what you guys do every day. So please help join me in welcome Victoria.
Thank you very much. Can you hear me well enough?
Yes.
All right, thank you. Thanks for that introduction, Lindsay. And good afternoon, and thanks to all of you who are still with us this late in the afternoon to hear me discuss a subject that's not really designed to blow your hair back with excitement. I'll do the best that I can to keep it interesting. And of course, I always have the most boring overhead slides, useful as a guide, but offering no visual stimulation whatsoever. And I hope you're okay with that. I've been asked to—
I was going to tell you, we can see you, but that's okay.
I did promise no visual stimulation, right?
Yes. All right. Thank you.
I'm going to, I don't mean to be rude. I'm going to continue looking to the side to reference my notes, and I don't want that to be a distraction. So I've turned off the camera for just a moment. So I've been asked to speak to you today on the subject of data analytics in health center reimbursement. And I'll confess to you, I struggled a bit with something to say about that, because for many years, reimbursement for FQHCs and RHCs hasn't involved or required much data analysis, which is something we should change, and it is changing. But where are we coming from, and what are the challenges that remain from that and that present themselves going forward? That's going to be the focus of my discussion. So just a brief history then. Data analytics in reimbursement is certainly not a new thing. It's been going on for a very long time. We're just analyzing different things now, analyzing things in different contexts than before, and analyzing a lot more things with a lot more data. For FQHC and RHC reimbursement, in the past and to a large extent the present, data analysis was focused only on cost analysis. Medicare has long reimbursed FQHCs with an all-inclusive per visit rate designed to address the average cost of a patient visit. And beginning in October of 2014, Medicare adopted a prospective payment system rate derived from a national average, inflated each year by the market basket, adjusted by a geographic index, and including a new patient differential where applicable. All of that was the product of a one-time data analysis project that focused on cost, and that created both the methodology and the PPS rate to which the reimbursement is still anchored. Medicaid reimbursement has been operating under a cost-based PPS method since 2001. Many states, and Arizona is among them, are using an alternative payment method, which is typically just a different way of calculating a per visit rate. In states that are still using the BIPA 2000 PPS methodology, even in states that are using an APM for that matter, given that there are limitations imposed by BIPA, FQHC and RHC reimbursement remains anchored in a cost analysis that was performed 2 decades ago. So annual inflation notwithstanding, it is a 20-year-old information that we're still operating with to reimburse FQHCs and RHCs. So as I move on to the next slide then, I'd like to preface it by saying, and this is kind of a disclaimer, I guess, that I share the following thoughts at the risk of sounding like I advocate doing away with the PPS rate. I don't necessarily, and that's not the point of my presentation, but I do think it's important to be conscious of some of its drawbacks as we move forward, with the current and future health center reimbursements, and hopefully by including much more data analysis than has been historically true. An all-inclusive rate prospective payment system is a reimbursement method that avoids data analysis. It eliminates work intensity in the rate setting, sure, and it grants a lot of predictability. Those are good things, but it also resists the introduction of new information into the reimbursement environment. A PPS method with its initial cost calculation and guaranteed annual inflationary adjustment was intended to perpetually yield coverage of the cost of treating a Medicare or Medicaid patient. We know it has fallen behind that. We don't know by how much. Some estimates would say as much as 20%. And it now yields what could only be called presumptive cost coverage. An annual inflationary adjustment can be a good thing, but it also misses the boat on important developments in the healthcare arena. Annual inflation fails to capture increases across the whole spectrum of costs that providers incur. Just for example, the cost of compliance and the cost of claims payment complexity. It also has limited ability to capture the cost benefit and operational benefit of clinical innovation or improved health outcomes. These things could be meaningfully brought into the reimbursement analysis using data currently available, but for the PPS framework, which by design is immune to it. So as value-based payment approaches are becoming a dominant theme in healthcare, FQHCs and RHCs do find themselves at something of a disadvantage, policy-wise, policy speaking. That is, the public payers are hesitant to include FQHCs and RHCs in value-based payment, or at least it could be said that health centers are not front burner in the VBP world. There are at least two obstacles that suggest themselves. Firstly, to the extent that value-based purchasing seeks to bend the cost curve down, health centers are protected by a reimbursement floor. And so providers see limited opportunity there, especially when you're talking about downside risk as well as upside risk programs. They don't see or they don't feel free to apply that to FQHCs. Secondly, to the extent that payers look to use value-based purchasing as a way to help providers get closer to cost coverage, and I believe Access is doing that right now in its long move back from the 2009 and 2010 rate cuts. In that context, then, that existing presumptive cost coverage in the PPS framework becomes a handicap. So historically, data analysis has not played much of an active role in FQHC and RHC reimbursements from the public payers beyond the upfront analysis that produced an initial rate years ago. There has been very little data input informing the reimbursement from year to year. There is a great deal of data output having the potential to do so. So value-based payment. Value-based purchasing is the big opportunity to introduce the power of data analytics into RHC and FQHC reimbursement, and to provide a way for the health centers to receive payment for activities that focus on and promote quality health outcomes and address the broader health-related needs of their patients. Though I think it's important to recognize that we are only in the nascent stages of that, and there are significant challenges going forward. The data needed for it exists. Pardon me. Health centers are creating the data with every claim that they submit. It accumulates in things like their own EHR systems, the Access Data Warehouse, the CMS Integrated Data Repository. The amount of data is mind-blowing that we have these days. Just as an aside, I need to throw this in. If you're a dinosaur like me, who was born into a world where computers didn't even exist yet, and the only assistance that you needed for an equipment malfunction was a pencil sharpener, we now have reams of data about what's going on in the healthcare business every day. We have programs like Azara, for example, and the health information exchanges that we saw an excellent presentation on just a bit earlier, that are finding ways to capture and organize and synthesize data into actionable information that can inform a reimbursement process if we use it that way. For several years now, the healthcare industry has been engaged in trying to put that data to use in accountable care organizations, value-based payment arrangements, shared savings arrangements, which many of the health centers present here today are involved in. And so far, all of this is being done with mixed levels of success. Some of the possible reasons for that. Firstly, I would say that shared data does not create shared objectives. Providers are wanting to use this data to help improve health outcomes, obviously, but also on the subject of reimbursement, providers are seeking to enhance reimbursement or at least to better target the reimbursement to where the costs are. Where the payers are actually seeking the opposite end. They want to reduce costs to themselves. Secondly, and this I think is very important, expectations of what can be done with data are not always in sync with what the data are really capable of. And so there is much time and effort, costly time and effort, being spent wrestling with all of its imperfections. And thirdly, the processes, the systemic and human operations that are trying to implement the use of the data are still the old claims processing framework that hasn't had sufficient opportunity to adapt. All that said, FQHCs and RHC reimbursement, states are starting to look at alternative payment methodology as a vehicle for introducing value-based payments. As you all know, Arizona is one of those states. At the instigation of the health centers, by the way, not even by their own initiative, at the instigation of the health centers in their leadership, Access adopted in 2018 the current APM, which incorporates quality measures into the rate setting calculation. It allows the health center to receive an additional upward adjustment to the annual rate update for attainment of minimum performance standards on 3 quality measures. Importantly, I think, as a data source, the Arizona APM is using information available from the HRSA Uniform Data System. This is a well-established, reliable, mature data collection and presentation system that is very easy to use to accomplish what the Arizona APM is doing. The method is streamlined, clear-cut, effective in helping health centers focus on specific quality goals, not work-intensive, and these are important things that are working toward its success. In addition, and in a sense contrasting that, several health centers are involved in value-based payment incentive arrangements directly with the managed care organizations. These kind of arrangements have great potential to maximize the value of quality data in reimbursements, and they may well be the way of the future. But presently, along with the obvious benefits of them, they are increasingly a source of frustration for both providers and for payers. The causes may be those already mentioned: differing objectives, differing expectations, most significantly, ill-adapted processes. The MCOs struggle to figure out how to make this all work. They really do. But instead of programs that use available data to focus attention on and efforts on goals, we see arrangements being built around data exchange, but often using task-specific reporting tools outside of the established and ordinary flow of data through the claims system. This adds a layer of work intensity whose contribution to value isn't immediately apparent. We have a lack of clarity, even disagreements about how to calculate the total cost of care in a value-based payment model. Different MCOs doing it different ways may actually be interfering with attainment of the program goals and disincentivizing participation in these programs. There's universal frustration about how patient attribution is being done. And so what could be discussions about real quality improvements in healthcare is quickly becoming instead about who or what is in the numerator or denominator of a formula. And so We also see quality-related goals being defined by payers rather than providers, who are by definition the experts in healthcare quality. So in a nutshell, we have abundant data analysis going on related to healthcare reimbursement, but in a rather chaotic way that may be leading away from the goal at this point. Now, I don't mean to sound like a pessimist about it all, but I just think that we might ask some questions about it and relook. Is the world of data analysis for health center reimbursements on track? Is it working? Of course, that depends on what working means. Value-based payment as an APM seems to be working well right now in Arizona. It seems to be working well in several other states, in that it has created and maintained a focus on quality measures and provides direct and clearly understandable reward for attaining them. But what about value-based payment incentive programs through the MCOs? Is it causing providers to give attention to quality measures? Yes and no. It's doing that where the quality measures are clear to the providers, which is certainly not 100% of the time, and where they are quality measures that providers believe in and understand to be indicative of healthcare quality, which is not 100% of the time. But there is no uniformity of approach among the MCOs, nor agreement between MCOs and providers. It's hard to make effective use of data analysis when you're not sure what it is you should be analyzing. This is an area of huge opportunity for payers and providers to work together in earnest to get on the same page. Is it enhancing or refining in a positive way reimbursements for FQHCs and RHCs? I can't answer that, honestly. Each health center would need to do the cost-benefit analysis, but I do know that sentiments are mixed on that right now. And so again, this is an area where payers and providers need to find a meeting of the minds. Is it bending the cost curve down for payers? Not yet, but that's a long-term goal. So in conclusion, data analysis for health center reimbursement faces many challenges right now, not least of all, an absence of agreement between payers and providers about how it should be done and what it should be accomplishing. Providers are looking for a way to use data analytics to change the reimbursement environment, to make it more responsive to the real world. And the payers are looking for ways to control and/or cut costs. And believe it or not, they mostly desire the path of least work intensity to accomplish that. These are not mutually exclusive aims. And in seeking the solutions, it may be helpful to recognize that providers are much more interested in data analytics for reimbursement than are the payers. And providers are much more enthusiastic about its potential than are the payers. And where quality health outcomes are the goal, providers have a much better understanding of how to attain it and how to measure them. So for that reason, rather than looking to the payers for guidance and solutions, providers should be leading the conversation. They should be leading every meeting on it. They should be helping the payers understand the importance of using data effectively and help them find a more efficient way to do it. That concludes my presentation. I thank you very much for your kind attention and for being here today.
Thank you so much, Victoria. Well deserved. Do we have any questions from the audience to Victoria? I do have one. So the APM negotiation is coming up to be due soon, right? I mean, we are just finishing the first try with this. So what will be your recommendation? You know, you mentioned the provider should lead, and we have, you know, people here from the different centers. So what would be your recommendation in how to become more active in regards to that, knowing that, you know, we're soon gonna need to choose the new measures if that's the route that we're gonna go?
If that is the route that it's going to go, and that's a good point. My recommendation, I don't know. I would say I do advocate that the health center should lead on this subject, but I would also point out that in this state, I don't know how The APMs came about in other states, but in this state, the health centers did lead. It was the Alliance and the health centers that they represent who approached Access and proposed the current APM that brings quality measures into it. And that is admirable, to say the least. But I would also, I guess, I would want to say that, again, providers are much more enthusiastic about using data for the reimbursements than the payers are. And so I think that we should approach that conversation cautiously, understanding that Access may or may not have the same interests that the health centers have, and may or may not be as enthusiastic as the health centers are about proceeding with a methodology that's currently being used. We just need to keep all the options open and go into that conversation knowing exactly what, as a provider group, we would like to see and exactly what we expect of Access. That I don't know if that's a good answer to the question.
No, it's perfect. Well, you have seen the evolution of this process, right, throughout all these years, and you had the chance to be, on the other side, and now you are in our, on our side, which is good. So I appreciate that you're here today. So thank you so much. I don't think that we have any questions from the audience or virtually. No. All right. Thank you, Victoria. Thank you so much.
Thank you.
For that question. Thanks.